Welcome back, everybody. Continuing with overcoming chronic diseases. We are now going to touch on the topic of arthritis. So let's get started. So the pathophysiology, arthritis is a chronic and often debilitating disease caused by inflammation of one or more joints, resulting in pain, swelling, stiffness, and limited movement. 46 million U.S. adults are currently estimated to have at least one of the more than 100 different forms, including the two most common, osteoarthritis, which is OA, and rheumatoid arthritis, which is RA. Individuals with arthritis tend to be physically inactive and deconditioned, which tends to accelerate the progression of the disease and increase their risk for associated comorbidities. Arthritis is now the leading cause of disability in individuals older than 55 years, but depending on the duration and severity of the individual's disease, disability may develop at a much earlier age. To date, there is no known cure for arthritis, but tremendous advances have been made in treatment and control that include evidence-based guidelines for disease management and recommendations for exercise. Osteoarthritis, which is also known as degenerative joint disease, which is DJD, is the oldest and most prevalent form of arthritis, affecting an estimated 27 million Americans. Osteoarthritis results from the deterioration or loss of cartilage in synovial joints, particularly in weight-bearing joints, followed by formation of bone spurs and subchondral cysts. Osteoarthritis is further characterized by its etiology. Primarily, OA is associated with the normal wear and tear of aging, whereas secondary OA is associated with injury, heredity, and other causes. Age is the strongest predictor of OA, in addition to obesity, injury, and finally heredity. Besides being the leading cause of disability in adults, OA accounts for 25% of visits to primary care physicians and half of all non-steroidal anti-inflammatory drug prescriptions. Early diagnosis of OA improves treatment options and prognoses. In addition to taking prescribed medications for relieving symptoms, individuals with OA are encouraged to make lifestyle changes, manage stress and depression, avoid joint damage, and balance rest and activity to help control symptoms and improve prognoses. Rheumatoid arthritis is a chronic and debilitating disease characterized by inflammation and swelling of the synovial membrane, the formation of pannus tissue within the joint, and the eventual deterioration of bone and cartilage, which causes swelling, pain, deformity, and loss of movement within the joint. Although the etiology of RA is not completely understood, RA is associated with higher than normal levels of the antibody rheumatoid factor, and as such is referred to as an autoimmune disease. There is no cure for RA, but the disease can be well controlled for most individuals with the right combination of medications, exercise, joint protection techniques, and other self-management techniques. So let's get into some effects on exercise response. The effects on exercise response. Inflammatory rheumatic diseases can affect cardiac and pulmonary function, as well as causing widespread vasculitis, which must be considered before individuals with systemic rheumatic disease are allowed to exercise. Vigorous exercise is contraindicated in the presence of acute joint inflammation. This would be symptoms where it's red, hot, swollen, or painful, all right? Or controlled systematic disease. However, the more common presentation of an individual with inflammatory rheumatic disease is subacute or chronic joint symptoms combined with possible sequela or previous systematic inflammation in the absence of acute flare-ups in people with systemic forms of arthritis. This is going to include rheumatoid and lupus. The degenerative and inflammatory joint disease have similar effects on exercise. Whether musculoskeletal, biomechanical, or cardiovascular, there are few differences among the various systematic forms of arthritis in terms of effect on the response to moderate exercise. In persons having an acute flare-up of systemic illness, the exerciser response can be quite blunted. Individuals with joint involvement tend to be less active and less fit than their unaffected peers. Resting energy expenditure may be elevated in people with systemic inflammatory disease, even when the disease clinically appears inactive or under control. Pain, stiffness, biomechanical inefficiency, and gait abnormalities can increase the metabolic cost of physical activity by as much as 50%. Joint range of motion may be restricted by stiffness, swelling, pain, bony changes, fibrosis, ankylosis. Inability to perform rapid, repetitive movements may affect exercise performance in terms of walking speed and cycle revolutions per minute. Site and severity of joint involvement determine exercise mode for aerobic and strength tests. Deconditioned and poorly supported joints are at high risk for injury from high intensity exercise or poorly controlled movements. Alright, so let's get into some effects on exercise training. Individuals with either inflammatory or degenerative joint disease are able to participate in regular moderate exercise to improve cardiovascular status, neuromuscular fitness, flexibility, and general health status. Improved aerobic capacity, endurance, strength, and flexibility are associated with improved function, decreased joint swelling and pain, increased social and physical activity in daily life, and reduced depression and anxiety. Disease-specific patterns of joint involvement should be considered during exercise prescription, monitoring, and follow-up assessments. The most immediate benefit of conditioning exercise in this population may be to diminish effects of inactivity, loss of flexibility, muscle atrophy, weakness, osteoporosis, elevated pain threshold, depression, and fatigue, which are problems common. Both inflammatory and degenerative conditions respond favorably to a low to moderate, gradual, progressed exercise program. Improved pain and function are found consistently in well-controlled clinical trials. The potential for conditioning exercise to have a therapeutic effect on the disease process itself has yet to be determined. So some of the medications and the management are as such. Joint protection exercise and education for self-management are essential components of comprehensive management. The goals are to decrease impairment, maintain or restore function, protect joint structure from further damage, and maintain healthier levels of physical activity. Ideally, care is coordinated in a multidisciplinary setting that offers preventative and rehabilitative care as well as medical management. To meet individual needs in an integrated program, the exercise component should incorporate joint protection and therapeutic exercise as needed. Health, safety, and successful exercise experiences for persons with joint disease can best be achieved by ongoing consultation with healthcare providers experienced in rheumatological care and rehabilitation. The major therapeutic goal in treatment of inflammatory rheumatological disease is to control the destructive inflammatory process. Medications prescribed to achieve this goal range from aspirin and other non-steroidal anti-inflammatory drugs, which are NSAIDs, to disease-modifying drugs, and those are your DMARDs. The biological response modifiers, those are your BRMs, which are designed to target specific immune processes believed to cause inflammation and tissue damage. Oral corticosteroids may be used when other drugs do not control inflammation. Combination therapies with two or more slower acting DMARDs is commonly used to provide maximum inflammation and disease suppression. Drug therapy is usually continued indefinitely, except when all signs of disease activity or progression disappear. In OA, your NSAIDs or acetaminophen is prescribed to manage symptoms of pain and stiffness. Local joint injections may be effective in both inflammatory and non-inflammatory diseases to alleviate inflammation or provide pain relief within specific joints or at other specific sites. Intra-articular corticosteroid injections should be given no more often than every 4 to 6 months. Because frequent injections can cause tissue destruction, the need to restrict activity following an injection is debated. However, vigorous, weight-bearing activities are probably best avoided for at least 1 week. Common medications. Analgesics, those are your painkillers, such as acetaminophen. Then there's non-steroidal anti-inflammatory drugs, which include the following. Salicylates, both acetylated, such as aspirin, and non-acetylated. Traditional NSAIDs, in other words, we're talking about ibuprofen, ketoprofen, and naproxen. COX-2 inhibitors, corticosteroids, methylprednisolone, and prednisone. Disease-modifying anti-rheumatic drugs, also known as DMARDs, include the following: azathioprine, cyclosporine, hydroxychloroquine, gold sodium thiamelate, leflunomide, methotrexate, sulfasalazine. Biological response modifiers include the following: tumor necrosis factor, also known as TNF, blockers, etanercept, Enbrel, infliximab, Remicade, adalimumab, Humira, anakinra, Kineret, interleukin-1 inhibitor, abatacept, Orencia, T-cell costimulation modulator, rituximab, Rituxan, and that targets the B cells. Recommendations for exercise testing. In spite of the challenges presented by joint pain and dysfunction in arthritis, exercise testing is safe and should be performed when indicated. Submaximal and subjective symptoms limited treadmill tests require less than 3 miles per hour, that's at 4.1 kilometers per hour, walking speed, and common psychoergometer. Protocols are well tolerated in this population. Early onset muscle fatigue may reduce the prognosis value regarding cardiopulmonary disease. Thus, if someone is suspected of having coronary artery disease, often diagnostic tests are recommended. Standardized tests of functional muscle strength and endurance are most commonly used to establish a baseline for exercise prescriptions, including 1 repetition maximum tests if performed correctly. Range of motion measurements are useful for persons who have limited flexibility and need stretching programs. Gait analysis may be necessary for those who have severe disease. altered biomechanics, and a need for orthoses. I'm going to throw a table in here. 34.2. Special considerations for exercise testing include the following. Pain or swelling may reduce performance. Vigorous, highly repetitive exercise should not be performed with unstable joints. Goniometry. Some arthritis involve cardiopulmonary systems, which may decrease performance. Spinal involvement may cause radiculopathy. Morning exercise should be avoided in clients with RA because of morning stiffness. Variable speed protocols should be available. Psychoergometers should have loose-fitting toe straps to accommodate genu-valgum. So recommendations for exercise programming. The major impact of joint disease on exercise programming is the need for joint protection. Thus, the following recommendations apply. Select low-impact activities and functional exercises for strengthening when possible. Stair climbing, contact sports, and activities requiring prolonged one-legged stance or rapid stop-and-go actions should be avoided in individuals with symptomatic hip or knee involvement. Muscles should be conditioned before exercise intensity is increased. Include flexibility and joint range of motion as key exercise components. Overstretching and hypermobility should be avoided. If pain or swelling appears or persists, reduce load on joint, reduce exercise duration and intensity, exercise in a pool or cycle or row. Shoes and insoles should be selected for maximum shock attenuation during weight-bearing activities. And if hip or knee pain occurs with weight-bearing activities, evaluate for rigid or semi-rigid arch supports for mechanical support or joint uploading. Exercise programs should also be designed with an individualized progression of intensity and duration. I'm going to throw in another table. 34.3. Use low intensity and duration during initial phases of programming. If necessary, exercise dose should be accumulated during several sessions throughout the day. Recommend alternate exercise modes and interval or cross-training methods to allow for changes in disease status. Set time goals rather than distance goals to encourage self-management and pace activity. Choose an appropriate exercise or fitness goal and recommend that the person not exceed intensity, duration, and frequency. Guidelines for training. Encourage exercise as a component of fitness routine that is part of self-management. Stretching and warm-up should be performed daily, even on days when the disease flares and vigorous activity is undesirable. Use aerobic activities that incorporate alternative forms of exercise, weight-bearing, partial weight-bearing, and non-weight-bearing to allow for migrated joint symptoms and changes in disease activity. Recommend that individuals learn a strengthening routine. Avoid activities that cause increased joint pain. Some post-exercise soft tissue discomfort may be expected. We're going to go in another table here. 34.4. So let's go over our sources. Evidence-based guidelines. American College of Rheumatological Subcommittee on Rheumatoid Arthritis Guidelines. Guidelines for Management of Rheumatoid Arthritis. 202 update. Arthroom 202-462. Ottawa Panel. Evidence-based clinical practical guidelines for therapeutic exercises and manual therapy in the management of osteoarthritis. Physical therapy, 205-859, 907 through 971. Yang W. Mowowitz, R.W. Nuki G. ETL. Recommendations for management of hip and knee osteoporosis, Part 2. OARSI, Evidence-Based Expert Consensus Guidelines. Osteoarth Cartel, 2008. Suggested websites: American College of Rheumatology, which is www.rheumatology.org. Arthritis Foundation, www.arthritis.org. And Osteoarthritis Research Society International, www.oarsi.org. Thanks for hanging out with me. You know, if you liked the video, subscribe, comment, share, hit that like button. You know, help me grow this thing, because you know what it is. If you don't help me grow it, no one will. So there you go. Thanks for watching.